the association between the phototherapy and epilepsy?
No, it's kind of an association that was found on statistical analysis. So it just gives more ammunition to say, okay, let's delay phototherapy a little bit and start it at a higher level, since it doesn't seem to be an issue with kernicterus much more. Probably people are paying more attention, so pediatricians are more alert. Bilirubin issues with the emphasis from guidelines. So that was mentioned in the guidelines. I didn't really go into details of the source article for the review. It all came out just actually published in papers this month. So it's very new. So I'll review it a little bit more, and hopefully next time I'll give you the exact analysis for the epilepsy part.
Okay, great. Thanks a lot. All right. Okay. So again, good evening, everyone, and good afternoon for those who are listening in Canada. I will be talking today about neonatal hypoxic ischemic encephalopathy, and I would like first to thank the organizing committee for the kind invitation. As requested, this is just a brief bio about myself, and moving forward, I have no disclosure to share with you. The objectives of my talk is really going to be we're going through the diagnosis of neonatal hypoxic ischemic encephalopathy. Hopefully, you will be by the end of the session able to, make a correct and clinical judgment about the neonates with encephalopathy, because I'm going to share with you some examples of the different spectrum of neonatal ischemic encephalopathy. The other part of my talk will be about how to make a proper management plan for neonates with HIE. And then maybe we can touch base, and I have a case that can mimic hypoxic ischemic encephalopathy. Hopefully it will be interesting to hear about this case. So as we all know, when we take the history about the maternal risk factors, and also what happened during the process of labor and after labor, we have to ask ourselves if the baby had sentinel event or kind of risk factor to go through hypoxic ischemic encephalopathy or hypoxic ischemic insult. In the old literature, there was more attention to the antepartum risk factors as a main reason for the hypoxic ischemic encephalopathy. But recently we learned that the intrapartum events are really important, and they actually maybe sometimes more important than the antepartum event. However, in general, we still don't have sentinel events, and we can't really identify the risk for the hypoxic ischemic encephalopathy in up to 25 to 50% of the cases, despite of all the history and all the signals that we can collect. Of course, as you can see here, the most common risk factors is the use of assisted delivery methods, the cord prolapse, placental abruption, whether it is complete or partial abruption, the cord prolapse, as I mentioned, and nuchal cord sometimes can cause that, uterine rupture in severe cases, shoulder dystocia. All of these factors, you have to try to dig into the history and see if there was any evidence of it. When we try to plan for the management strategy, first of all, you have to establish diagnosis of hypoxic ischemic encephalopathy. And with establishment of the degree of encephalopathy, you can also get some hint about the prognosis, because as we will talk shortly, we sometimes have to make prediction for the prognosis as early as it can be to make a decision and to counsel the parents about what's the next step. Once you have the diagnosis or the suspicion of the HIE, then you ask yourself, whether this baby will be qualified for the standard therapeutic hypothermia, which, as you know, the standard kind of care now for these infants, if you have the facility to do that, because there is strong evidence that it is effective and decrease the risk for neurodevelopmental challenges later on. Is the baby stable enough to begin with to start therapeutic hypothermia? This is an important question we will try to talk about. Are there comorbidities to consider with the therapeutic hypothermia, particularly meconium aspiration and pneumothorax secondary to that, PPHN, hypotension, all of these comorbidities that they can come together And what would be the neuroprotective measures that we have to take besides therapeutic hypothermia in the management of these babies? And always keep in mind the differential diagnosis for the hypoxic ischemic encephalopathy, because even though you started therapeutic hypothermia, you have to also consider that, we started therapeutic hypothermia based on the initial encephalopathy, but is there something else that we should consider? So in the initial few hours after birth, we don't have too much information, and we have to take a rapid decision because, as you know, therapeutic hypothermia has to start as early as it can be, because we have time window for the start of therapeutic hypothermia, ideally within the first 6 hours. So we have to collect the information, as I mentioned, about the ante and intrapartum risk factors. And then we have to also collect the information about the acidemia that happens in the cord gases and also postnatal gases. If you don't have a cord gas, then you can rely on the initial postnatal gas. However, you have to keep in consideration that this gas can be affected by the degree of resuscitation that you initiated on this baby. Then the neurological assessment, which is a key piece here. You have to have the skills to assess the neurological condition of the baby. And also you have to consider what's going on also with the baby. Did we give the baby any anti-epileptic drugs? Did we give the baby any sedation to manage his irritability or her irritability, or to manage the PBHN? Because this all can contribute into your neurological assessment and your judgment about what's the next step. Of course, the gestational age and the postnatal age are, putting us in limits, because as we know, therapeutic hypothermia is not yet approved as a standard of care for infants less than 35 weeks of gestation. And evidence-based medicine showed increased mortality and increased side effects if you use therapeutic hypothermia for preterm infants, even if they are late preterm infants, such as 33-weeker or 34-weeker. So you have to limit your therapeutic hypothermia to what is kind of evidence-based approved. Of course, the postnatal age, as I mentioned, 6 hours is a gold standard. If you have a patient who is late a little bit, arrive to your unit or arrive to the facility for therapeutic hypothermia at the age of, for example, 7-8 hours, you can still argue that it can get benefit. Experimentally, there was no benefit of therapeutic hypothermia after the age of 8.5 hours. In our practice, we sometimes extend therapeutic hypothermia to the age of like 12 hours, depends upon the case. But beyond that, there is no evidence that it is really going to be effective. So based on these factors, you're going to decide whether the baby is eligible for therapeutic hypothermia. And if you are to decide to initiate therapeutic hypothermia, you're going to make sure that you have all the facilities to monitor this baby. So ideally, this should be practiced in tertiary care center when you have all the neurological tools that you can use to monitor the therapeutic hypothermia and the neurological assessment of the baby. Or the patient is not really eligible for therapeutic hypothermia, and we will be talking about that. Or the patient is really severe enough and really comatose and severely affected by the brain damage to the degree that we would prefer to not initiate therapeutic hypothermia because the patient is not going to get benefit from that. I'm not going to go into the details of the SARNAT. We all know the SARNAT that we are using. So far, we're still using the SARNAT staging to help us to the degree of the encephalopathy and take the decision. And as I mentioned, so far, the moderate and severe encephalopathy group are the group that approved or kind of evidence-based that therapeutic hypothermia can benefit. There is a big debate about the mild group, whether they can safely receive therapeutic hypothermia, and also it is effective or not in the mild group of encephalopathy. And of course, as I mentioned, the severe group, there is spectrum itself inside the severity, and if it is severe enough to not really expect any benefit from therapeutic hypothermia. Recently, we have been using, and I think many centers are now using Thompson score as well in conjunction to the SARNAT. The beauty of the Thompson score, I think it gives you a number by the end. So you can have like a threshold that you can create as a guideline for your institute. In our institute, we usually use 7 to decide if the patient is eligible for therapeutic hypothermia. Of course, if you go to the literature, you can also classify the infant according to this classification if the patient is mild, moderate, severe. As you can see here, mild encephalopathy is defined anywhere between 0 and 10. But in our practice, we're still using 7 as a cutoff point because we think patients, based on our data, patients more than 7 are really in the moderate group, not in the mild group. Let's move to some cases, and then we can hopefully learn some information or some lessons from the cases. So first case is a call came to us from obstetrician from hospital level 1 nursery about full-term baby who was born 1 hour ago with nuchal cord around the neck. There was no heart rate tracing in the prenatal recording for uncertain period of time. Patient delivered with meconium-stained amniotic fluid. He was flaccid, heart rate less than 100, so received chest compression for 10 minutes. Epinephrine was also given by ETT, and intraosseous line was established. He had no spontaneous breathing for 23 minutes, and he was eventually gasping after that on 100% oxygen and saturating 80s. The cord gases were not severely acidotic, and there was some degree of acidosis here, 7.1. Postnatal gas was significantly acidotic, 6.8. At 2 hours of age, the assessment remained to be concerning. No suck, no gag, no response to the pain. At 2 hours of age, again, the patient started to show other neurological feature, which was in the form of clonic seizures, and received lorazepam for that. Our team arrived a little bit late because the patient was far from us. The patient remained quite encephalopathic, and despite that, he had vital signs that are stable. Parents were in the room and waiting for our counseling, what to do next. I'm going to answer the question because I think, we are late in time, so I don't want to, spend a lot of time of waiting for the response from the audience. But the question here was really, is the patient is going to be benefiting, like getting benefit from therapeutic hypothermia or not? And we felt that we have enough data to say that the patient has been exposed to hypoxic ischemic event that is significant enough to cause this degree of acidosis and this degree of early seizures and early, very concerning neurological exam. So we informed the parents that we are not really sure that if the patient will be able to make it and survive. And if the patient is to survive, we will be very concerned about the long-term outcome. And we are not really seeing the benefit from therapeutic hypothermia. Parents agreed on that, especially because the patient was far up from us. In the ideal case scenario, and if the parents are not really keen to take this decision quickly, you can bring the baby to your institute and discuss later on to make an autopsy and make some metabolic workup, because yet you have some evidence that it is most likely going to be hypoxic ischemic encephalopathy, but this kind of early decision needs also some verification and some ruling out of the other etiologies for encephalopathy, especially if it happens too quickly like this. Let's move to case number 2. We had a patient who was full-term infant with 3.5 kilogram. The mom had history of depression and receiving medication. She had some maternal temperature at just before the time of delivery. The delivery was vaginal delivery, but there was non-reassuring fetal heart rate, so it was assisted with vacuum. The Apgar scores were 2 and 4 and 6. The patient noted to have some loose nuchal cord as well. Patient required some positive pressure ventilation and noted to be hypotonic right away after birth. And as you can see here, the umbilical gases were concerning again. The pH on the venous side was 7.16, CO2 49, bicarb is 18, base deficit -11, and the cord umbilical gas was, as expected, more acidotic, 6.9, CO2 36, and bicarb is only 9. The initial assessment showed that the patient is quite encephalopathic. As I mentioned, you can lie him in the moderate to severe category. So his Thompson score was 12. And again, his first venous gas showing metabolic acidosis going on. So the first question we have to ask ourselves now, is the patient eligible for therapeutic hypothermia? Do we have evidence that this is HIE? Well, we have evidence that this is HIE based on the fact that the patient has some degree of intrapartum hypoxia from the cord gas acidemia and from the base deficit. And there is also nuchal cord that can give you a kind of risk factor for the hypoxic ischemic insult. The patient is less than 6 hours, so he can get benefit from therapeutic hypothermia. Patient is full-term infant. So according to our criteria, the patient is eligible for therapeutic hypothermia. So the decision was made that the patient will be started on passive cooling. The patient quickly extubated after the initial resuscitation and weaned on the CPAP to the degree that later on he was off CPAP. I'm just going to show you his background on the amplitude integrated EEG. The amplitude integrated EEG showed this continuous normal voltage here, as you can see here. So the question here, when we have this patient on admission, you have a continuous normal voltage, yet you don't have yet the sleep-wake cycle, which is more reassuring than the continuous normal voltage even. You have some, improving neurological examination. So the patient at 7 hours of age, his score was down to 2. And this is his admission blood gas as well. So some clinical questions or some practical questions: should we stop therapeutic hypothermia then? Like, the patient is now at 7 hours of age, scoring only 2. His examination is really reassuring. And his background on the amplitude integrated EEG is, near to the normal. There is no sleep and wake cycle yet, but he is having normal continuous voltage and no seizures so far. So in our practice, we don't usually tend or recommend to stop therapeutic hypothermia if we have already decided to start therapeutic hypothermia based on solid criteria, including the core gas acidemia and the initial high encephalopathy scoring. So we tend to continue that. And that's, I think, the safest way to go, even if the patient is showing transient improvement or what we call the progressive improvement of the degree of conscious level and activity. That doesn't mean that the patient had a hit. So the recommendation is really to continue with therapeutic hypothermia. We have to also consider continuous monitoring by the amplitude integrated EEG. Other question may people ask is it good to give a sodium bicarb here to correct for the acidosis? My answer with that would be no. In this case scenario, as you can see here, there is degree of acidosis here, but it's going to be corrected spontaneously without need of sodium bicarb. Especially if you don't have like a washout compensated or compensation of the metabolic acidosis by lower CO2. You may need to use the bicarb in other case scenarios that I will be talking about later on. If you have a patient with PBHN and you have a patient with low PCO2, and you want to help the patient to improve the acidosis and prevent pulmonary vasoconstriction, you can use a bicarb in this case scenario. But in this case, there was no indication to use the bicarb. Should we continue with the antibiotics? In our practice, we continue with the antibiotics for the first 48 hours until we get the result of the blood culture, and then we will discontinue the antibiotic. I'm gonna just quickly show you the presentation or the clinical examination of the patient after rewarming. This is a patient with moderate degree of encephalopathy, mild degree of encephalopathy. Can you see the video first?
Yes.
Okay, perfect. So the patient is somewhat tachypnic, but not needing respiratory support at this moment. He is responsive to handling, spontaneous eye opening. He's actually doing spontaneous moro here. So far reassuring. Again, this is post-rewarming examination. He had relatively acceptable sucking. It's not the best, but you can call it diminished sucking here. He's started on feeds, but by the nasogastric tube feeding. Examining his muscle tone, looks like the appendicular muscle tone is appropriate, so it's not hypotonic. Examining the reflexes, I think this is interesting. I hope that you can see the deep tendon reflexes. You can see that it is brisk reflex and even spreading to the other side of the body. So when she's stabbing now on the patella, you can see the movement on the other side. So this is hyperreflexia, which something you don't expect really in the beginning of the course of the HIE, but you can expect later in the course of the HIE infant. They remain to have some sort of neuroirritability and some sort of hyperreflexia. So in summary, this patient, showing some axial hypotonia and some degree of hyperreflexia. So we were actually glad that we continued with therapeutic hypothermia. We got as usual, the brain MRI after rewarming of this patient, and this is very reassuring brain MRI, because as you can see here, there is nice posterior limb of the internal capsule T1 hyperintensity, so very good assuring signal here. And there is no diffusion restriction that you can see here on the diffusion weight images. So if I ask you what would you anticipate, or what would be the most likely outcome of this patient, I hope that you will all agree that the outcome will be normal. And this is what happened in this patient. His outcome was gladly normal. Despite of the lesson from this case, that despite of the initial assessment of the degree of encephalopathy, he was classified in the moderate to severe group. Despite of the degree of acidosis, I think this patient got benefit from therapeutic hypothermia, and his course improved significantly over the course of the next few days, and his MRI showed reassuring brain images, and his outcome was favorable later on. Moving to the next case, this was a full-term baby, again, 40 plus 5 weeker, 4.5 kilogram, was born by emergency cesarean section due to cord prolapse. There was also some fetal tachycardia and non-reassuring fetal heart rate. Cord gases, and remember to compare between this gas and the other gas that we talked about, less acidotic, in fact, here, and the UV was 7.4. 48 of CO2 bicarbonate or base deficit minus 13, the umbilical artery 7 and minus 14. The baby was born with hypotonia and covered with meconium. Heart rate was 60 to 80, stimulated as usual, given baby V, did some suctioning of large part of meconium. Baby then cried and then got apneic again. Heart rate was dropping down to 60, started CBR or chest compression. And then patient improved after that and was on CPAP. But then intubated afterward due to apnea. And in the view of respiratory effort, he was connected to the ventilator. And as you can see, the settings here were up to 100%. And was only setting 92 preductal and 81 postductal. The postnatal gas was 6.8, significantly acidotic, and the CO2 was quite high, 98. Lactate was 12.8, and the patient at this moment was showing minimal spontaneous activity and minimal kind of response to the handling, but was minimal, and weak primitive reflexes. The UPGARs were given 1, 4, and 5. Now, if I ask you this question, now you have a baby who is encephalopathic, but you have a baby who is now ventilated with very high CO2, and you have a baby who is in hypoxemic respiratory failure. You have a baby who is on 100% oxygen and have borderline saturation in the preductal side and actually desaturating postductal side. So this is an example. Again, I'm not going to expect the answer from you, but this is an example of a comorbidity that can happen with the HIE. So this patient definitely is showing element of PBHN here, because we have difference between the pre and postductal saturation, and he's evidently showing oxygenation failure here. So the action item should be, we should ask ourselves now, if you are to be asked, is this patient eligible for therapeutic hypothermia? I would answer yes. Patient is eligible for therapeutic hypothermia. Not necessarily based on the UV, but based on the UA and based on the fact that he had sentinel events, yes. Based on the fact that he's encephalopathic, yes. Based on the fact that his postnatal gas yet acidotic, but there is some sort of metabolic and respiratory component here, but I'm really worried about the lactate as well. So yeah, I mean, the patient would be eligible for therapeutic hypothermia. But if you ask me, would you start therapeutic hypothermia now? Would you start turning the warmer off? I would say no, because the patient is not stable enough to start therapeutic hypothermia. So you have to First, adequately ventilate this infant. You have to try to minimize the handling and adequately sedate this infant because you have now element of PBHN. You have to reduce the pulmonary vascular resistance and try to get over the pulmonary hypertension component by using nitric oxide if you have nitric oxide available. If you don't have nitric oxide available, inhaled nitric oxide available, then your work should be focusing on correction of the acidosis, as I mentioned before, because acidosis can increase the pulmonary vascular resistance. Correction of the hypercarbia, of course, but avoid being hypocarbic as well, because hypocarbia is not also helpful for their brain perfusion. Maintain robust and, even on the high side, systemic vascular resistance and blood pressure. So you have to deal with any hypotension and keep the vascular resistance on the systemic side, on the high side, to compensate for the increase in the PVR. So in order to do that, you're going to need time. You're going to need at least a couple of hours. So I would encourage in these cases to not jump into therapeutic hypothermia and take the time to stabilize the patient, improve the oxygenation, improve the blood pressure. If you have any comorbidities that can be fixed quickly, such as, if we are talking about another scenario, like a patient with placental abruption or a patient with fetal-maternal hemorrhage, and the patient is, profoundly anemic. You have opening hemoglobin of 5 grams per liter. Then you're going to have to take decision to correct that before you consider therapeutic hypothermia. If you have a patient with DIC or bleeding, oozing actively from the umbilical stump, then you have to deal with that. You have to correct that before you consider therapeutic hypothermia. So I would take the advantage of the first few hours and the window for therapeutic hypothermia to correct for that. Yet, as early as it can be, you start therapeutic hypothermia. Now, the other clinical question that people usually ask, would you consider this patient not eligible for therapeutic hypothermia just based on the fact that he has significant PPHN? I would say no. The patient needs therapeutic hypothermia if he is eligible for, because this is mainly the evidence-based medicine that we have that can improve the long-term outcome. Usually PPHN and all of these acute hemodynamic instability can improve with time, but the neurological consequences that can happen later on, you can't really fix that later on. So you have to make the effort as much as you can to fix all of these items and start therapeutic hypothermia as early as it can be. I don't want to speak too much about, what kind of agents that we should be using for improving the blood pressure here, but maybe I can just, spend, half a minute about that, because I think this is also important clinical question. And I know that Yasser speaks a lot about the hemodynamic management of patients with HIE. But the bottom line is in this case scenario, you want to make sure that the blood pressure is on the high side. Blood pressure is not on the low side by any means. You have the options of using limited normal saline boluses as a rescue if you don't have access for inotropes or vasopressors. Don't use too much. That would be my advice, because as you know, the patient is already in brain edema and brain inflammations, and the patient is at risk for AKI, acute kidney injury. So you better restrict the fluids on these patients as much as you can. Yet you can use normal saline bolus because theoretically hypoxemia can cause peripheral vasodilatation. So you need to fill the tank by some fluid in case you need that. If you are to move to using inotropes and vasopressors, dobutamine is good drug that you can use to support the myocardium, but in the same time can give you tachycardia. Dobutamine can cause some degree of lowering of the blood pressure, so wouldn't be my first choice. Dopamine, I know it's available in Egypt and can be readily used. I do support dopamine as long as you don't have pulmonary hypertension, because dopamine can increase the PPR, so it's not recommending if you have element of PBHN. If you don't have element of PBHN and you just have HIE, dopamine can be your friend and can be used with a small dose, 5 to 10 mic. Then you have the options of using other inotropes and vasopressors like epinephrine, like norepinephrine, like vasopressin. Epinephrine can be used to give you alpha and beta effects. You can have inotropic effect and vasopressor effect from the epinephrine, yet it can give you some degree of hyperglycemia and lactic acidosis. Norepinephrine is a vasopressor, as you know, so it can be used for the SVR, but not really if you have myocardial dysfunction. And finally, vasopressin, if you have access to the vasopressin, it's a good agent that can give you increase in the SVR and can significantly improve your blood pressure and can also decrease your PVR in a way or so. The downside of the vasopressin is that it's going to cause water retention and can cause hyponatremia as well. So you have to be careful with that and make restriction in the fluid. For the sake of time, I'm just going to briefly, again, show an example of a case with moderate encephalopathy here. This was the patient that I was talking about. Let's see that. Hope that you can see it. So in compared to the other patient, the patient here is a little bit hypertonic. So there is increase in the muscle tone. You can't really open the popliteal angle even up to 90 degrees. Patient is irritable and hypertonic. This patient, the difference between this patient and the previous patient, the patient here is in the first day of life. So the patient is not expected to have hyperreflexia here. So reflexes are normal. Patient doesn't tolerate any handling. This patient, as I told you, this patient had PBHN. So you better do your examination and or the handling quickly because they shunt a lot across the PDA and they can desaturate with any handling. Speaking about that, you're gonna have to use some sedation, including morphine or midazolam, but you have to be careful when you use the sedation because it can lower your blood pressure. So you have to make a good balance between using sedation appropriately to manage the PBHN, but also not to use it too much to lower your systemic vascular resistance. This patient, to begin with, had this discontinuous background on the amplitude integrated EEG. And as you can see here, he had at some point electrographic seizures. Wasn't really picked up clinically, it was mainly electrographic seizures, as you can see here on the raw EEG. And then he had his MRI, which was somewhat reassuring in a degree or so. There was no lesions you can see or diffusion restriction in the basal ganglia or the thalami, yet there was, as you can see here, high signal on the splenium of the corpus callosum, some white matter injury here, some watershed white matter injury here as well. So if I would ask you what kind of expectation you have for this patient who was quite sick in the beginning, had oxygenation failure, improved significantly after the measures that we have taken for the PBHN. Neurologically, as I mentioned, he had seizures, discontinuous background, and this kind of abnormality on the MRI. So if I ask you this question, again, I would vote for mild disability as a risk factor for, or as a risk probability for this patient. But in fact, the patient, when we assist him at 36 months of age, was beyond the expectation to us. So he was surprisingly and fortunately better than what we were expecting. So cognitively, he was superior in his percentile. Language-wise as well, he was very appropriate, and motor-wise didn't have some sort of disabilities and was walking, running, doing what you would expect to do. So that was a good course for a patient who was quite sick, and I think he got some benefit again from therapeutic hypothermia. The next case is Dr. Sameh. Am I good with time? Are you okay?
Yes, Dr. Amr.
All right. So case number 4 is, again, a patient who was full-term. The mom had history of depression, had history of abortions. Serology was protective and GBS was negative. The pH here was less than 6, as you can see, and it was, again, mainly respiratory here. The cord gas on the venous side was, again, respiratory, but also there is metabolic component. This is the bicarb, the base deficit -22. The anatomy scan was normal. There was rupture of membranes artificially done because of the history she had with the abortion, and the baby was born by vaginal delivery, suctioned twice again for a lot of meconium, and was noted to have meconium all over him. The Apgar scores were 1, 3, 5, and 6, and he needed oxygen delivery, BBV, intubated. Again, he was lethargic, hypotonic, no spontaneous activity. Initial Thompson score was 13, which is quite high. And the Cernat staging was severe encephalopathy. So the decision was made right away that the patient is eligible based on the cord gas acidemia and based on the fact that he had meconium. So he had some degree of acidosis, fetal distress. The cord gases, of course, the Apgars were low and he was quite encephalopathic. So it definitely fits into the criteria for therapeutic hypothermia. And he reached the target of therapeutic hypothermia at the age of 5 hours. So on the other hand, you see this patient doesn't have a lot of comorbidities here, just meconium, but, we didn't have too much trouble weaning him from 100% oxygen down to 30% oxygen. In fact, he was extubated nicely to CBAB and even CBAB room air. But, the difference here that this patient had profound encephalopathy. So as you can see here, the background was pulse suppression on the amplitude integrated EEG, and he had multiple seizures here, as you can see. He had evidence of multi-organ dysfunction, so the liver functions were quite high. He had some degree of also renal affection, so some degree of AKI. His the near-infrared spectroscopy readings were not reassuring because this is too high on the cerebral side. 92 is quite high, which usually we explain it by decrease in the oxygen extraction in the brain because the brain is really encephalopathic. So the brain is not really extracting oxygen. So that was really concerning. Yet, I'm going to show you the examination of this patient first, and then we can discuss what to expect. Let's go here. All right. So this patient, again, I would like you to compare it to the previous ones. This patient from the first glance, this patient is profoundly hypotonic. He's taking frog leg position, as you can see here. So just by posture, without touching him, he is flaccid, hypotonic, not reactive even to the handling. There is no anti-gravity movement, you can see. The scarf sign is profoundly abnormal. His mouth is open here on the CBAP. This examination was done after forming. Very encephalopathic, oculomotor hypotonia here. So severely encephalopathic patient in compared to the previous ones for sure. All right, that's his MRI. And the MRI, as you would anticipate, will be concerning because his clinical examination was concerning and his amplitude integrated EEG or EEG background was concerning, and he had seizures. So all the risk factors are there. So as you can see here, there is diffusion restriction in the basal ganglia here, and the thalami, the optic radiation here, and the subcortical white matter here. All of the bright, hyper-intense white signals are indicating abnormalities. So it's a mixed pattern of injury, not only the white matter and cortex, but also the deep gray matter. And if you look at his MRS here, the spectroscopy, he has lactate peak, which again is a poor prognostic sign. So with this information, this patient is expected significantly to have severe disability. The patient yet was not intubated and was weaned actually off CPAP, and the patient survived. The patient survived. Parents were counseled, of course, about the severe disability, and the outcome was very unfortunate. The patient had infantile spasm later on. That's mainly related to the degree of affection in his basal ganglia, and had spastic quadriplegia, was not able to sit, was not able to roll. He was wheelchair dependent. and his head circumference, as you would expect, was not growing. So you can see the discrepancy between his percentile and the head growth and the weight and height. So definitely sad outcome. But as you can see here, some patients like this, they can survive despite of the initial course. All what they need in the beginning is really to breathe and to feed. The patient was obviously feeding by G-tube, was not able to take oral feeding, but the patient was breathing by his own. So that's an example of extreme case, extreme spectrum that despite therapeutic hypothermia didn't get benefit from therapeutic hypothermia. Last case I will present here is about a lady who was 28 years old, and the pregnancy was otherwise uneventful. The patient was induced at 41 plus 2 weeks of gestation. There was vacuum-assisted delivery. The choric gases were mildly acidotic. The Apgar score were 3 and 6 and 7. Patient required resuscitation, including BBV, and there was no respiratory effort in the beginning. So patient was initiated on CBAB and then intubated after that. His course was really significant. In the beginning, he had some degree of encephalopathy, but not to the degree that you would anticipate based on this choric gases. He had seizures at 24 hours of age, and the severity of encephalopathy was worsening over the next 3 days. I'm just going to go quickly through his examination with you. So this patient was intubated, was again profoundly encephalopathic. You can see that from his muscle tone here, very flaccid, hypotonic. Again, his mouth is open, which is always concerning. When we examined him, it's not showing on the video, he had no suck and no grasp and no gag reflexes. And this is his background on the amplitude integrated EEG. It was flat tracing almost. So definitely very concerning exam. But what was concerning actually is that the patient was not like this in day one. The patient progressively showed encephalopathy over time. When we did the MRI was surprisingly different than we were expecting. So the patient had a pattern that we suspect with metabolic disease. So the patient had diffusion restriction in the posterior limb of the internal capsule. The corpus callosum was not well developed, so there was hypoplastic corpus callosum. And also the patient had high glycemic peak on the MRS, which is really characteristic for non-ketotic hyperglycemia. So the patient went through the different testing for non-ketotic hyperglycemia that included having serum glycine level and concomitant sample from the CSF, which confirmed a high level of glycine. And the patient was diagnosed with non-ketotic hyperglycemia. So you have to remember, as I mentioned earlier, that there is always differential diagnosis of the etiology for encephalopathy. One of them is also the metabolic cause for encephalopathy, and this case was a good example of encephalopathy related to a metabolic reason, not really to the hypoxic ischemic encephalopathy. They can definitely mimic hypoxic ischemic encephalopathy. The last slide I have to say here that what are the red flags that you should be considering in these cases. So if you have family history of neonatal deaths, if you have family history of encephalopathy or neurological problems, this is something alarming that could be metabolic or genetic condition. If the patient or the mom is reporting hiccups in the intrauterine course during pregnancy, seizures, abnormal movements, or lack of movements. No definitive history of fetal distress, like there was no sentinel event. However, I said before that 50% of cases you don't have a sentinel event, but you still have some degree of fetal distress, which can be indicated by the fetal heart rate, non-reassuring heart rate, meconium, stained amniotic fluid. All of these things, yes, they are not sentinel events, but indicating that there was some degree of fetal distress. If you have infection setup, or not. If the encephalopathy, as I mentioned in the last case, was progressive, if the seizures are not really controllable and intractable, because this is something that we don't see in HIE. Usually seizures are well controlled easily, not really refractory seizures. If your primary presentation is really hypotonia rather than encephalopathy, then it is another flag that this is not HIE. If the patient is looking around and looking active, the background on the amplitude integrated EEG is normal, but the patient is profoundly hypotonic. This is against the HIE. If you have atypical image, as I mentioned in the last case, or atypical EEG or lab findings, then you have to consider other causes for encephalopathy. Finally, I would like to thank my colleagues, all my colleagues here in the neurocritical care unit at SickKids, and all the families of the patients I mentioned who give us the consent to share these cases with you. Thank you.
Thank you very much, Dr. Amr. Can I ask you a question?
Of course, Dr. Sam.
For hypoxic ischemic encephalopathy, cooling should be started within 6 hours, isn't it?
That's right.
Okay, but of course I understand the better, but if there is no nearby center for head cooling, total body cooling or head cooling, is it wise to transfer to another area with the facilities after 6 hours, or?
Yeah,
No.
I mean, I think, thanks, Dr. Sam. You know, I totally understand the situation when there is no nearby center to provide therapeutic hypothermia in the time window. I think it is still reasonable to transfer the baby if you are to anticipate the transport to, or the baby to reach to the referral center or to the tertiary center within the frame of, I would say, 12 hours maybe.
12.
There is some work from Dr. Shankran before from US showing statistical benefit from extending the therapeutic hypothermia window to 24 hours. But there is always a debate about, whether it is clinically meaningful benefit or not. In our practice, we don't really see benefit from therapeutic hypothermia after 12 hours, so we tend to not to do that. So,
thank you very much. Are there other questions? دكتور ناجي.
معاك يا حبيبي، يلا wrap up.
دكتور علاء. دكتور عمرو.
يوم جميل عظيم، يعني very very nice speakers, updated topics, very very updated subject also. Speakers are excellent, simplify a lot of difficult but now became simple subjects regarding genetics, newborn, metabolic, neurology, cardiology, everything. Thank you very much for this great effort to collaborate and to collect all those scientists from everywhere abroad. Thank you very much.
Okay. Thank you very much, Dr. Amr, Dr. Alaa, Dr. Michael Narvi, Robin Alvero, Dr. Yasser Sayed, Amr El Shahed, colleagues, friends. Thank you very much indeed. Thank you all moderators, Dr. Salma, Dr. Adalia, Dr. Yasmin, Dr. Nagi, my dear friends. Thank you very much. without your support, without your help, these events couldn't be possible in this way. Thank you very much, and let us meet next year, inshallah, 2023, on the 28th and 29th of September. Thank you very much.
Inshallah.
Thank you, Dr. Sam.
All our
Thank you so much.
ألف شكر يا دكتور داليا، شكرا جزيلا.
ميرسي جدا جدا.